Well, you have heard about the definition and pathophysiology of refractory angina. And I think the problem of refractory angina is going to increase in our country in the coming years, primarily because of an increase in the aging population and also because of improved survival of patients with coronary artery disease with modern modes of therapy. When we look at the problem of refractory angina, there are several challenges that come up in studying this disease. Primarily because there is a lack of consistent terminology and a clear definition of refractory angina. And different publications and databases have used several acronyms depending upon how they perceive that this is a difficult to treat or untreatable patient, and it has been variously named as advanced coronary artery disease, refractory ischemia, end-stage coronary artery disease, refractory angina, and no-option disease. Inter alia, as you have heard before, the scope of this problem might include several varieties of patients. For example, patients remaining symptomatic despite medical treatment with or without a PCI or a CABG. And in such patients, the frequency of daily or weekly angina actually ranges from 2 to 24% in routine publications. There can be concurrent microvascular disease after successful treatment of macrovascular disease, like for example, persistence of symptoms immediately after a so-called successful intervention on an epicardial coronary artery. There can be coronary vasospastic angina, or as we know that there are several pathophysiological mechanisms that are responsible for angina, and if the patients are not receiving treatment that is consistent with the mechanism responsible for their angina, can turn resistant. And finally, the patients with so-called no-option disease. Let's first look at the prevalence of anginal symptoms in stable coronary artery disease, because refractory angina often talks about stable coronary artery disease alone, or chronic coronary artery syndrome as it is now called. In the Clarify registry, which is a very large registry of 32,000 patients, 20,000 patients underwent a stress test and 20% had angina. And out of these, only 3.2% had Canadian class 3 or 4 angina. And this would be the typical group of individuals whom one is likely to encounter as cases of refractory angina. In the Danish registry, on the other hand, consisting of 11,000 patients, there were patients with angina with no obstructive coronary artery disease, defined as either a normal coronary angiogram or diffuse coronary artery disease without a focal stenosis, and more than 50% had class 2 symptoms. There was a higher risk of MACE in these patients with a hazard ratio of 1.52 to 1.85 compared with people who had no symptoms of angina. You've just heard the European Society of Cardiology definition that, for sake of repetition, I'll have to say it again, the long-lasting symptoms for more than 3 months due to established reversible ischemia in the presence of obstructive coronary artery disease, and that's a very significant caveat here, which cannot be controlled by escalating medical therapy with second and third line drugs, bypass surgery, or percutaneous intervention, including PCI of chronic total occlusions. Unfortunately, the ESC has not included refractory angina in the absence of obstructive coronary artery disease, and we all know that patients with microvascular dysfunction or other non-obstructive coronary artery disease can be one of the key drivers of symptoms in patients with refractory angina. Another definition has been suggested by the Duke University, And that actually classifies these patients into 4 phenotypes. And they define or propose a definition as symptoms of angina with objective evidence of ischemia of minimum 3 months duration despite maximal tolerated doses of anti-anginal medication, Canadian class 1 or 2 angina with at least 1 cardiac admission per year, or class 3 or 4 angina with 1 or more than 1 of the following phenotypes. Phenotype A is minimal epicardial disease, and the ischemic deficit is caused by diffuse microvascular dysfunction. Phenotype B has limited epicardial disease, such as a single vessel disease like a chronic total occlusion or a branch vessel disease, and the CTO typically is more than 20 millimeters long. Type C is diffuse disease, such as a vasculopathy or typically diabetic coronary artery disease, which is, one is unable to stent or bypass. And last is the end-stage disease with multiple prior interventions, CTOs, failed grafts, and presence of 2 or 3 vessel disease, not amenable to further PCI or CABG, or a prior failed revascularization due to in-stent restenosis or a failed bypass surgery. Now, it's very difficult to collect data on no-option refractory angina, and most databases have actually looked at the frequency of symptoms in these patients and the presence or absence of multi-vessel disease. And I have quoted a few sources, starting from Euro Heart Survey, where patients defined as ineligible for revascularization were about 14%, in the Cleveland Clinic Consecutive Series, 11.8%, Minneapolis, 2005 to 2008, 16% of the patients were considered suboptimal for revascularization, and 6.9% were no-option disease. And in the Duke University database, 32% of the patients went on medical treatment despite 2 or 3 vessel disease. We know that patients vary remarkably in the intensity of symptoms when they have angina, and here is an attempt made to find out what is the actual number of these patients in the community that have real difficult angina. And there are 2 types of database. One is based on cardiac catheterization and the other on population-based study, and both are in the form of pyramids, and we see that the actual number of patients of angina are rather large, but those with class 3, class 4, or disabling angina actually just form the peak of this pyramid, and approximately 7 to 15% of the patients with coronary artery disease in most databases suffer from difficult angina. Let's now look at the long-term prognosis of refractory angina, and unfortunately the long-term prognosis does not seem to be very good. As we see from this optimist registry, 1,200 patients, median follow-up of 5 years, and 5-year mortality was 20%, and a 9-year mortality was close to 30%. And there were multivariate predictors of all-cause mortality, namely age, diabetes, angina class, kidney disease, left ventricular dysfunction, and presence or absence of heart failure. And these patients had very poor quality of life, multiple morbidities, repeated hospitalizations because of uncontrolled symptoms. And compare this with a pooled analysis of randomized controlled trials that compared CABG with PCI in patients with left main and multi-vessel disease. And in 5 years, the mortality rates with PCI was about 11% and with CABG about 9.2%, vis-a-vis a 20% 5-year mortality in refractory angina in the optimist registry. And there have been several reasons given for suboptimal revascularization status, and multiple reasons could be present in the same patient, namely CTO in the large majority of them, diffuse disease, diffuse vein graft disease, no conduits for CABG, collateral dependent circulation, multiple restenosis, and presence of comorbid conditions. We should also remember that small but a steady rate of recurrent revascularizations actually happen in 6 to 10% of such patients of so-called no-option disease, and they are generally confined to new lesions, new restenosis, but also because of enhanced expertise in the heart team in dealing with high-risk PCIs, or CABGs, and therefore a constant reappraisal of such patients is required because the conditions may change, the expertise may change, and the patients might get benefit out of both of these. And lastly, I would like to summarize the implications of refractory angina. It's a highly disabling condition with poor quality of life, high morbidity and mortality, resulting in anxiety and depression. Frequent outpatient, emergency, and inpatient treatment is needed in these. There is a high resource utilization and productivity loss. There are many novel technologies which have been applied to these patients, including some advanced procedures, but they are often attempted without the usual mandatory clinical trials. And impact of these new treatments that you are likely to hear in the coming presentations on morbidity, quality of life, and survival actually needs additional research. Thank you very much, ladies and gentlemen, for your kind attention.